morning, everyone. My name is Brinley Cons, and I'm the founder of HS Connect. And I'm here today with Katie Scherling, who is an advanced registered nurse practitioner and certified wound care advanced practitioner, also certified, in hyperbaric medicine. She works full-time in an outpatient wound care center and has been treating wounds for nearly 10 years. She is passionate about the care of HS patients because helping them understand their condition and what their treatment options are has helped make an immense impact on their quality of life. Thank you so much for joining us today, Katie. I appreciate it.
Yeah, thanks for inviting me.
So now we'll jump into the legalese for just a minute. Katie's opinions here are her own. They do not reflect those of her employer or not a reflection on her employer, that she has no financial or personal interest or disclosure related to this presentation or the products that we're going to talk about today for wound care. So today we're going to cover some of the basics for wound care. What do I do with these holes that I'm left with after a wound, abscesses and drains? How do I cover, or what kind of products can I use for these wounds in very difficult areas to bandage? So those are some of the things that Katie's going to talk to us about today. I'm going to go ahead and give her control of the screen so that she can show this wonderful presentation that she created, which we will have available afterwards. We're also going to list all of the products that she shows and that we discuss as well. So you'll have access to those in the video. So go ahead, Katie.
Great, thanks, Brinley. So I wanted to add, I realized the last piece of the legalese is that while I am a provider and licensed in the state of Washington, that the things we're talking about today, it's important that you talk with your provider about, and that if you have any questions or concerns, that seek medical advice with your provider before initiating any of these therapies if you have concerns about them. Okay, so let me share my screen here. What I'm hoping to do is, create a dialogue. And so I didn't create a PowerPoint, but more just sort of a running log of topics. And so Brinley, if there's any thoughts that you have as we go along and questions, just feel free to interject. And I'm hoping to kind of get through the introductions and talking about the physiology, or like what causes hidradenitis, and the broad treatment options, and then narrow down into topical management as you discussed, because that's kind of what I do as a wound care provider and where I specialize. So we'll get started here. I think that anyone who has hidradenitis, and we'll just refer to as HS going forward, if that's okay, knows that, or has done any research, there's a lot of concepts or biases out there that only certain people get it, and you only get it in certain times in your lifespan. But really what we're understanding is that hidradenitis can happen, anyone can have hidradenitis, and it's been documented in all ethnicities and ages. We're trying to change that perspective and identify it early, or as early as possible, because people can be, and you might have experienced this too. I think you have a daughter, right, an adolescent who
Yes.
has HS. So that's important for people to understand. And then a lot of folks say, like, why me? Why is this happening to me? It's painful. It's disruptive to the quality of life. And it feels like, am I doing something? Should I be doing something different? Why is this happening to me? And the more we understand about HS, the correlation between, I just want to make sure, are you guys able to hear my background noise? No, okay, good. So 40% of patients report a familial history, and there's increasing evidence that there's likely a genetic component to this condition. It is not related to a person's hygiene. Obesity and smoking are talked about a lot in relation to HS, but it does not cause HS. And we'll talk a little bit more about lifestyle modifications and what's kind of put out there, but what we now understand about evidence-based correlations and lifestyle modifications. But it's important for people to know that just because you smoke or just because you're overweight doesn't mean that that's why you have HS. And I like to say to my patients, it's not you, it's the disease, and so really putting that in context and being able to set that aside and recognize that it's not you, you're not doing anything.
Yes, very much so.
So what causes HS? We don't really understand. And is this large enough? Do you want me to make it bigger, or
No, I think it's perfect.
Okay. We don't fully understand what causes HS. Our understanding is growing, and we now believe that there's a genetic propensity to this condition, resulting in a hyperinflammatory response. So how common is this condition? As with a lot of things in the literature, it's somewhat variable, but we think it's somewhere between 1% and 4%, or that's what's been reported. Our growing awareness of the diagnosis is suggesting that this disease is more and more prevalent. And that's why we used to say, 1% 10 years ago, and now it's like pushing 5%. So really maybe not that rare.
Well, and we're also finding, just as a side note on that too, that a lot of people, they may have HS, not know what they have, or are not seeking treatment for it. So that's one of the reasons why I think that the prevalence could be lower than it actually is. And I think most of us can attest, if you have HS, that as soon as you talk about your HS, you know quite a few people in your small circle that actually have it. So it's really interesting that I think because it can be hidden so easily for most of us, we may not actually have an actual, a prevalence that's accurate for that yet.
Yes. Yeah. And that's definitely the underreporting bias is something that's talked about a lot, and that we are likely underreporting this. Just because of how in the short period of time that this has become a focus in dermatology, the rates have increased exponentially. So the point being is you're not alone. This is a disease, a condition that many people that you may know actually have. So how do we determine the treatment, and how do we evaluate the response to therapy as patients and as clinicians? I think that's the other thing right now that we're trying to forge, is this mutual understanding of how do we treat HS in a comprehensive way, and think about not just the disease process from a clinical standpoint, but how do the symptoms associated with HS affect patients' quality of life, and how do we address all of that, or help patients with resources to address all of that. So treatment recommendations are based on the extent of skin involvement to some degree, the presence of secondary lesions. So we talk about the staging and severity of the disease is sort of how we initiate stepwise therapy. But again, the point and kind of caveat I give to this is that while the initial approach to this was identifying the stages, the early stages of the disease, and basing our recommendations on those stages, with more understanding of the disease and looking at imaging, like ultrasound imaging, we recognize that even the stage 1 may have really significant disease burden under the skin. And so it's not, I think somebody who really understands hidradenitis as a clinician and treating it with their patients doesn't just wholly stick to the staging and say, oh, you're stage 1, you should just be responding to topical therapy. Why, but if they're saying that they still have pain and there's swelling around those nodules, then the disease burden is likely much more significant than a stage 1 would indicate. So stage 1 typically is the presence of singular abscess or nodules without extensive scarring or sinus tracking. And that's what we consider stage 1. And we can see those in both skin tones here. And then stage 2 is typically the presence of multiple abscess and moderate scarring and sinus tracking in a wider area, or multiple areas of the body. And then stage 3 is that really extensive kind of diffuse involvement, multiple interconnecting sinuses and abscesses, frequent flares or occurrences, not many periods of relief between flaring, or maybe a constant flare or inflammation. And so let's see where we're going here. how do we evaluate our response to treatment? That's kind of what I talked about before is, it's not just about reducing the number of lesions. Yes, that's something we incorporate into, is this effective or not? But it's also about the severity of the inflammation, the amount of pain somebody's having. Have they been able to improve their quality of life, increase their activity level, their range of motion, meaning can they move more, do more activity that they want to do? So all of those are part of what we use to assess how effective we're treating this with patients. And this is something that I highlight because I try and recommend to my patients that as we look at treatment modalities or we initiate therapy, like keeping a record is really helpful. There are these clinical tools for assessment, but I think they're primarily used in research, and we don't, as clinicians on the day-to-day basis, necessarily use them with our patients. But doing something as simple as saying, okay, record the number of lesions or the number of flares, or what activities are you able to do or not able to do over the next weeks or months, and bringing that in and evaluating that gives us a more, organized approach at helping patients and ourselves understand if what we're doing is helping.
Yeah, and what areas you're getting them in and what the frequency is, because all of those things for patients start to run together. So I think that's a really good point in keeping track of that. And that's one of the things that we just created a flare and lifestyle tracker journal on the site too, that you can pull off, as it's one of the resources on there. So we'll link that in the description as well.
Yeah, and maybe before we upload this, we can pull that link and just like set it here.
Yeah, absolutely.
And then people can click on it easily. And so as I was saying, that like as clinicians, we base our treatment recommendations somewhat on the disease severity, the clinical assessment of the disease severity. And so we'll look kind of at the approach. I'm just going to grab my notes here really quick as we jump into this. So management of hidradenitis is multifaceted and usually involves multiple specialists. So that might be often is a dermatologist, potentially a surgeon, a plastic surgeon, and a wound care specialist. And so in more mild disease, we think about topical management, and that might be with a topical antibiotic is often a common start, or a topical steroid or a retinoid, a vitamin A therapy. And then local surgical efforts, like maybe an incision and drainage, maybe a deroofing procedure, but we'll talk a little bit about the pluses and minuses of those minor procedures. And then as the disease severity increases, then we often will initiate systemic therapy. So that's something that affects the whole body instead of just treating it at the local level and on the skin. And so oftentimes that's an antibiotic therapy. And I think this is where patients might get a little bit confused, because while hidradenitis can lead to a secondary infection sometimes, most of the time there's no infection going on. There's inflammation, but not an infection. But why are we using antibiotics then? The antibiotics that we use in HS have an anti-inflammatory property. And it's really that anti-inflammatory property that we're utilizing to try and reduce the inflammation associated with the flares. And with antibiotic therapy, it's typically initiated and then prescribed for a fairly long time. It can be weeks to months. When we initiate antibiotics, and you can let me know what you think. Typically, patients have a fairly good initial response. Usually they come back and go, oh, wow, yeah, I feel better. But there's usually limitation to that. My experience is that over time, they stop responding to the antibiotic. Plus, you have all of the potential side effects of the antibiotic over
resistance.
So like if you actually did develop an infection, the longer you're on an antibiotic, you potentially could be developing a resistant bacteria, making it harder to treat an actual infection.
Yes. Yeah, it's definitely one of the things that we're conscientious about with the antibiotic recommendations is that, you know, and then typically if one doesn't work, then they try another. So now you've gone through, you know, 3 to 4 to 5 different antibiotics, and now you're developing a resistance potentially to 3 to 4 to 5 different antibiotics. So it's definitely something that you want to proceed with caution with that.
Exactly. And then I want to caveat on the flip side with, like, I think there's a place for antibiotic therapy as an initial kind of emergent, you know, like an emergency use, or I don't know, not even emergency, but it's like, let's get this under control, but let's not just say that this is where we're going to stop. And that's what I talk to patients about when we start the antibiotic therapy is, look, you're going to be on this probably for an extended period of time, but while you're on this, we need to be talking about the next steps, whether that's an immunotherapy, and that's sort of the next step, systemic immunotherapy, which is a non-antibiotic therapy. There are sometimes it's a steroid therapy, but again, that's not typically we don't keep people on steroids for a long time. It's maybe used for a short period of time, but then usually it's a non-steroid immunotherapy. So Humira or adalimumab and infliximab are the two FDA approved non-steroid immunotherapies. And I'm not going to go into this potential side effects. That's definitely something that needs to be discussed with a dermatologist. But I think that it's important. A lot of patients, they know that their symptoms get better when they're on antibiotics. So it's like, can I just be on antibiotics? But we need to recognize that that's not likely a long-term solution. And if we're needing the antibiotics, if you're on a long course, we stop the antibiotic and it just comes back, which is highly likely, the reoccurrence rate is very high, then, or if the disease severity is so significant, multiple locations, that you've had to have emergent surgery because of the degree of abscessing, then just a sustained antibiotic therapy is unlikely to be the primary therapy. And then, of course, you know, what do we do about pain in the acute setting? Over-the-counter pain medications are where we would typically start, but they're often not sufficient. And so having a good relationship in this case with either your dermatologist or your primary care doctor who really understands the disease and the flares, who's willing to engage in a pain management strategy with you, is really important.
Yeah, this is definitely an area that most of us struggle in. I know a lot of dermatologists do not prescribe pain meds no matter what.
Yes.
So having a good, you know, relationship, like you mentioned, with your GP, who knows about your condition and the severity and potentially talks to your dermatologist and works together with them on a pain management strategy may be a good idea. Because unfortunately the over-the-counter meds can be a joke for most of us, even if you're combining, you know, Tylenol and ibuprofen. It just doesn't even touch the abscesses. So thanks for touching on that. That's a huge component of HS that's commonly overlooked because it's just a skin condition. So people who don't truly understand how painful it can be, they don't understand exactly the need for that pain management. Yeah.
And I don't want to belabor this point too much, but you know, the regulations for providers to prescribe narcotic pain medication has been increasingly tight. And so oftentimes with these chronic pain issues, we have to engage in a pain contract. There's a process. And I often have to talk to patients about, like, this, we're not saying you're drug seeking. We're not saying you're a drug addict. We're not saying any of those things. We just have to be mindful and, you know, careful in the way we go about this and so engage the process is what I just keep encouraging people. Just stick with it, engage it, and hopefully.
It's not a personal thing.
It's not a personal thing.
Yeah, exactly.
So we talked a little bit about this, the surgical management options of this condition. And I just want to look at some pictures really quick. So there's sort of, I'm like trying to do math in my head, but there's local surgical procedures. So that might be an incision and drainage, or a de-roofing procedure. So these are some pictures, and I guess I should caution people, we're going to get into some photos here. And so if you have little ones around or you're squeamish about images, we are going to look at some surgical images so I want people to be aware. So we'll just give people a minute and then I'm going to go forward. Okay, so local incision would be literally that. They take a scalpel and they make a small cut to help open the skin to drain that abscess. It's a simple procedure. It's a fairly, it's not very uncomfortable. It's done very quickly in the office. It usually results in good pain relief, immediate, fairly quick pain relief for the patient. But the rates of reoccurrence are very high. It's like, we can drain this, but it's likely to just close back up and then reoccur. So it's not recommended again as a maintenance therapy, but it might be used intermittently to relieve pain.
It can also lay down so much scar tissue sometimes in the healing process that it can impede your ability to have further surgeries there, or in some cases. So it's something to be conscientious about as well.
I've not heard impeding in the future, but definitely the creation of scar tissue could cause issues, especially if your disease isn't under control. So if lesions are developing underneath scar tissue, they're going to be deeper, they're going to be harder to, they're likely to spread, underneath and create these really large, deep abscesses. So for a number of reasons, this IND methodology is not ideal, but I'm not going to say we don't do it and that it doesn't provide pain relief in an acute situation.
Yes, exactly.
Oh my God, some feedback. So that's all I'll say about that. In post IND, like after it's been drained, you don't need to pack these wounds. That's kind of the old adage is, oh, fill this wound so it doesn't reoccur. That's typically uncomfortable for the patient. They're unlikely to be able to do it at home. In most cases of an abscess, we will do what's called a loop drain, where we put two incisions and we put a little drain and it's tied, and that keeps those openings from closing and allows the fluid to continue to drain. To be honest, I don't really know if that's appropriate in hidradenitis because it's not a typical abscess. It's not this singular unit that we're draining an infectious process from. This is an inflammatory skin with lots of sinus tracts. So what I would recommend, or what I do recommend for patients, is once it's drained, just a pad dressing to absorb the drainage, and it doesn't need to be packed. This is the deroofing procedure. And so this is a better option for smaller lesions with few sinus tracts. And this can be done in office as well. So there could be a wide deroofing or these sort of individual lesions where they've taken a circular kind of biopsy tool. And what that does is it removes the whole shaft, the inflamed area, and then it heals by just filling in. We call it secondary intention, where it's not sewn closed, it's just left open and the body fills in the tissue. And covering something like this, again, it's whatever is comfortable. It doesn't have to be occluded. You don't need to put something on there like a lot of tape. Patients think that it needs to be tight and covered, and that's not really what's important. What's important is a moisture balanced environment. So if there's still drainage from the wound, then it's going to be moist. And you could just put something very simple over it, whatever's comfortable to you. If it's not draining, if we've been able to remove the whole capsule or follicle inflamed area, and maybe they've cauterized it, they've used something to stop the bleeding, in those cases, those wound beds aren't necessarily moist anymore, then I would be saying use a emollient. We can talk again about Vaseline versus a lanolin or A&D ointment or Neosporin. But we just want to keep moisture balanced. So there's hydrogels too. There's little gels that is basically just water in a gel form. And those can be placed in, and it's usually soothing and then covered with a simple cover dressing for something like this. And then something larger, if they do a larger or wider excision, again, these might be done in office, something of this size, but much larger than that, then it's probably going to be done in the OR, in an operating suite. These open wounds, they are going to bleed more. They're going to be more painful because there's all that exposed nerve endings. And in this case, we tend to step up our therapy to something a little more specialty. And that's where we go in and talk about like our Hydrafair Blue, and we can get into that a little bit more. But we think about a dressing that might help stimulate tissue growth and provide a little antimicrobial benefit to reduce the risk of a secondary infection. However, the caveat there is that some of those dressings are really expensive, and there really isn't any evidence to say definitively that one dressing is better than the other. So when we go back to basic principles of wound healing, we want to create a moist environment, a moisture balanced environment, not too wet, not too dry. And we can do that with some really inexpensive products. So we're going to get into that a little bit more. And then the most advanced surgical procedures, or I guess most invasive, not advanced, but most invasive, are these wide, large excisions for areas of extensive HS that might occur, well, anywhere. But these wide excisions may be left to heal in 3 different ways. By secondary intention, and that's what we talked about here, where they just literally scoop out the tissue that is affected. You're left with a very large, potentially a very large wound, and you have to figure out what to do. Do I pack this wound? Are they going to order a negative pressure dressing, often called a wound vac? And that's where a wound care provider or a surgeon who's willing to engage with you is really helpful to help guide that process.
So as someone who's had a wide excision, even if your surgeon is not pro wound care, request it. They cannot tell you that you don't need it. They cannot tell you that they will not recommend it. They may decide, they may think that it's not necessary, but you as the patient ultimately get to drive that decision.
Yeah.
My surgeon in particular did not feel like wound care was something I needed. He's used to going home every day looking at these kind of wounds. Anybody who isn't, it's very, very shocking at first.
Yeah.
And I feel like for your peace of mind as well, going to a wound care specialist, even if you're going once a week, to be told that you're healing the way that you should and to get the best care and help for healing, it really does good for your mind, which then in turn helps you heal properly as well. And you get to celebrate how much skin growth you've had each week, which you really didn't do much to facilitate other than carry on with your normal life. But there's something really gratifying about that. And to be told that like it's looking good and healing and you're doing the right things is really helpful with your course of care as well.
Yeah, definitely. And I think where surgeons come from is like, well, your body's going to do the work, so it doesn't matter. Because it is true to the extent that we don't have evidence to say that one dressing is better than the other. But what wound care does, like you said, is give the patient tools, because you got to cover it with something, like you got to put something there. And so we can kind of help decide what works for you. And we can also help order products. Many insurance cover products, and we understand that process. And if we can get your insurance to cover something, we'll do it. So
yeah, that's another really good point, because the dressings you may not be able to afford on your own, but if you go to a wound care specialist like Hydrafair, for instance, and it's not even a product I knew existed prior to having wound care. And for me, it's wound healing on steroids. The way that it took care of my wide excisions was like nothing I ever experienced. So wound care specialists can help you get those products through your insurance, whereas you wouldn't be able to do that on your own.
Yeah. And then just briefly, so these wide excisions are, we'll talk about the healing process, but the other option, or sometimes what is done, is a skin graft. And this is not a very good picture, but you can kind of see this little tissue mesh that's laid on the skin here. And that tissue is usually taken from another part of the body, like the top of the thigh, and then laid on the wound bed to let that top skin, what we call epithelium, grow over. That may be done at the time of the surgery, but typically these hidradenitis wounds are so deep that it has to grow in first. So there's this type of closure is usually delayed. You heal for a couple of weeks, and then they come in and put that skin graft over the top. And then the other form is an actual flap. And this is done at the time of the surgery. So they would do the wide excision to remove all the inflamed tissue. And then they make special cuts in the muscle to move tissue around and actually close it up. And so when you wake up, you don't have this big wide incision. You're actually just have these incision lines that are sutured closed. And the reoccurrence rates with this sort of flap procedure versus a graft versus these wide excisions healing by secondary intention is that the reoccurrence rate is about the same. I don't know if you have heard in the community of surgeons that are doing more of this type of closure.
No, most of the ones I know do the via secondary intent, and the reasons being is with a graft, first of all, it takes longer to heal. You have 2 wound sites instead of 1. And because you're moving skin from one part of the body to another, the likelihood of reoccurrence is higher.
So this is a graft, and this is a flap. The flap is all from the same place. You don't have another wound anywhere else. It is done all in the same location. Whether this is possible or not, I think has more to do with the extent of the disease. So do they have enough tissue left over to move things around and close it? So when you're done with this procedure, you only have these suture lines here. You don't have another wound anywhere else. And again, there isn't evidence to say that one is better than the other at this point in terms of reoccurrence of disease. But I think that when you're interviewing surgeons or looking to consider your options, know that that wide excision is not the only option. And that if your surgeon doesn't work with a plastic surgeon, that I think it's okay to ask, do you work with a plastic surgeon? And just explore your options and know that you have multiple options, and weigh the costs or the risks and benefits for you, because it's going to be different. So let's talk about healing time. We're like, wow, we're getting into it. When a wound occurs, there's essentially 3 phases: inflammation, proliferation, which is like that healing, that growing in, and maturation, which is what's happening underneath the skin once it's healed. We typically think 4 to 6 days for that initial inflammatory phase. And then your healing phase, when the tissue is growing in and covering up, is 4 to 24 days. But this is highly variable. And then I think the important thing to understand is that, and this is hard to read, but even when that skin is closed, 21 days to 2 years, your skin is healing underneath. And so scar formation is occurring for a long time, and remodeling of scar tissue is happening for a long time. And so when we think about these surgical procedures, if we're doing an IND, that small little incision, that's going to heal probably in a few days, but the likelihood that a new lesion is going to reoccur in the same area is very high. The de-roofing, those sort of open, larger wounds, they're going to take probably closer to weeks to heal, less likely to have reoccurrence, but still higher than the wide excisions that we talked about. But the healing from a wide excision is weeks to generally months, because they're so large. And even when you have that flap procedure, it may look closed, right? You have smaller incisions, but that you're healing underneath for a really, really long time. So we talked a little bit about what do we do with holes? Do we pack them? Do we not pack them? I'm going to keep going on that because I feel like we talked about that. Do you agree? Okay. So let's talk about difficult areas to secure dressings: the back of the neck, the groin. A lot of these areas are difficult, right? Just to be honest, like, how do I get a wound to stay, or a dressing to stay here? How do I get it to stay here? How do I get it in my bottom, on my groin? So there are these kind of occlusive dressings that come with a bordered adhesive, and we call them island dressings. I just gave a picture of what those look like. They're basically gauze. They usually sometimes have a non-stick coating on them. And then they have this usually cloth type tape, and they come in multiple sizes. And if you're looking for them online, you can type in bordered gauze or island dressing. And that will get you, a plethora of options and different price ranges, or if you're going to a wound care center. What I remind folks is, like, if you put like the back of the neck, often what we'll do if we can't find one big enough, then we'll just cut it, we cut right here, and then we secure the next one to it, and we kind of build it out, and then secure it like that. For some patients, a silicone border is more comfortable, and there's lots of dressings. There's foam, there's non-foams. But if you type in a silicone bordered dressing, that's going to give you something that's adhesive, but maybe more gentle on your skin in terms of coming on and off. And you can also buy silicone tape. So this is one brand, very common brand, that you can find at the store or online. And silicone tape adheres fairly well, and it's also very gentle on the skin. This tape that's around these border gauze, we often refer to as Medipore. It's cloth. It has little holes in it. And I would say generally patients tolerate that pretty well, but for some, the silicone is better, especially if you've had surgery or scar tissue and a re-traumatization of the skin. It can be really sensitive. And then this is the one I like to put out there on Amazon. It's polymem foam, and it comes in a big roll, so 24 inches, that's 2 feet. So that's fairly affordable for so much dressing and in a roll form. So some people don't think about it like, oh, I got to get these sheets, but this one comes in a roll, and you can cut it to any size, shape you want. And the benefit of this dressing is that it doesn't stick. So it's very gentle coming on and off for folks, but it's not adhesive. It does come in an adhesive form, but the adhesive forms are always more expensive. And this gives you the option to sort of cut it to size and put it where you want it.
So then you would just tape this down on the edges once you've cut it.
You could tape it, or we can talk about some other modalities. I like to suggest this burn netting to folks. It's called wound netting, or oftentimes burn netting. And you can let me know what you think. I don't know if you've used netting to secure dressings. Have you?
I think in my armpits when they first did them, that they kind of put it around. Yeah.
Yeah. So you've got to kind of work to figure out what works for you. And then I did put a sizing chart here, so people, when they're looking for it online, have a sense of like, okay, what is a 4, 5, 6? So they're often listed by number, and then you can find, okay, the number is this wide, and it's usually used in these areas. And I always tell people go bigger than smaller. And as you can see kind of on this modeling, there's different ways to use it. So like here, she's taken a tubular portion of it and essentially like put it over and then cut out this side. And then she's been able to, I'm trying to think how she probably did her arm here, but we've done this with patients as well, where you would do a cut like in here, and then they can sit their arm through, and then maybe another one here, and then the dressing is held by this one, and then the one that's over the body.
It's also like Project Runway wound care style.
It is, exactly. Yeah. And then the thing that I didn't put in here, but I want to grab really quick, are surgical underwear. Have you heard of surgical underwear?
Yep. They are fantastic.
That? Yeah. And do you have a picture of that on your?
I don't know if we have those on the site, but that's actually one of the things I'm working on, is an underwear and bra section. Okay. So that's definitely going to be in the underwear and bra section.
We'll put it in here too. But basically it's mesh. It's not this necessarily. It's more of a cloth. It's kind of like what she's wearing here, but it's breathable. It's super stretchy. So that is either called surgical underwear. It's called postpartum underwear. And I think that's great because it's stretchy, it's breathable. You can put pads inside of it and pull it up, and it comes in lots of sizes.
Yeah, the only caveat I would say on that is a lot of times that the thigh is not as stretchable. That's one of the things we've been struggling with, is finding a brand that has a more stretchable thigh area.
Mhm.
So just, when you're looking at the sizing charts on those, just use caution on that, because
Yeah.
they can be a little bit tight.
Okay. Yeah. And I also, like with all this stuff, I'm like, go bigger. And then you can, because they all do I agree, tend to run kind of small. So there's that caveat. Okay, let's jump into, I don't know if do you want to while I'm talking, pull open the website, and then we'll go through some products on your website, HS Connect. Oh, you're muted.
Yes, and then I think I can share my screen as well.
Yeah, I can stop sharing. And so when you pull that up, what do I want to go through here really quick? We're going to look at these topical products. A lot of people ask about medical honey. Should I use Neosporin or should I not use Neosporin? My short comment on medical honey is that it's anti-inflammatory and it's antimicrobial, but it may increase drainage. So it's osmotic. It's sugar. It's going to pull fluid. So I think there's no harm in using Meta Honey, and I think that it makes sense in this condition because it is anti-inflammatory. So if you're using something that has honey in it and you find it effective, I think that's great. I think it can create moisture balance if you have a drier wound, but if you have a really wet wound, then it may not be the right product because it might actually increase moisture in that wound area. But again, it's also used, I think you have a deodorant product on there, and I'm thinking in my mind, well, that makes sense. Like it's anti-inflammatory, it's antimicrobial, and those are two components of HS that we think about as being contributory. So I think it's a reasonable usage, and it comes in a lot of different forms. Would I recommend paying a lot for an expensive dressing that has honey in it? Probably not. But using it if you have a cream or an ointment or a deodorant that has it in it, I think that there's concepts about what honey does that make sense with HS. And then Neosporin versus Vaseline versus some of these other ointments. This comes from a moisture balance standpoint. We want wounds to be moisture balanced. So we often recommend a salve of sorts. Neosporin tends to have a higher rate of dermatitis. People react more to Neosporin than other forms, kind of more straightforward petroleum or emollient based ointments. And more recent or the research has shown us that in terms of reducing infection, Neosporin doesn't seem to have any increased benefit than Vaseline. So
yeah, we were told just a petroleum jelly
yep,
which makes perfect sense.
Mm-hmm. And then from my perspective, I prefer A&D ointment to just straight Vaseline. It's a little bit more expensive, but vitamin A and vitamin D are great for the skin and do help with wound healing, maybe reducing inflammation. So I tend to recommend A&D ointment. And then also lanolin products are, I want to say they're better, but again, I prefer lanolin based over petroleum based. And you kind of have to look at the active ingredient on that. And the concept there, again, I don't know if there's specific research to support this, but lanolin is an emollient. So it moisturizes the skin and it protects from moisture, keeps moisture in the skin. Petroleum is kind of like, it just is an occlusive. It goes over the top of skin. So you think that it's moisturizing the skin because it feels oily, but it doesn't actually penetrate to moisturize. It really just keeps moisture in. It creates a film. And so it's also petroleum based. So it's a byproduct of petroleum oil. And so there's something to that, that kind of, I just don't like. Not to say that the petroleum is in a lot of products, and it's been shown to be very safe. So I don't want people to think that it's not safe. But if you can find a lanolin based, that's a more natural fatty oil that will penetrate and protect from moisture loss. And it's interesting because the boilies, I was looking at that, and I've had a lot of HS patients swear by boilies. And it is a lanolin. It has petroleum in it, but it has lanolin before petroleum. So I just thought that was interesting. I'm like, oh, I was looking it up today. I'm like, oh, that's nice. So
Yeah, that is interesting.
yeah, let's talk about cleansers really quick. Do you have cleansers on the website?
Yes, we do have, let me see. Okay, so product suggestions. We do have some wound wash.
We recommend using a hypoallergenic mild wash, wound wash, pH balanced. And so most of your wound cleansers, like your Vash, are going to be pH balanced, and they're going to be on that hypoallergenic spectrum. But I think that it is okay to use over the counter, Cetaphils, those sort of fairly inexpensive dermatology recommended hypoallergenic washes. It's common for providers to recommend a product called Hippoglens or chlorhexidine, which is kind of like a dilute bleach wash. And again, there's no evidence that we have that says using this helps, but a lot of case reports and patients report that using an antimicrobial wash reduces flares. So I think it's reasonable to consider and to try different things to find out if it's working for you. The other one that was listed is benzoyl peroxide. I think somebody asked about that. I would not recommend benzoyl peroxide to patients. It's too cytotoxic, meaning it can hurt good tissue as well as reducing bacteria, but I think it's more likely to cause inflammation and be too caustic on the skin. Zinc-based skin cleansers, often we see those used for like dandruff or psoriasis, which is also an inflammatory condition. So I think that there's some good, it's a reasonable consideration to try a zinc-based skin wash. And there's lots of like bar soaps and different liquid soaps that have a zinc, if you look at the product active ingredient. And then I think that's all I had on those two things. That, really reasonable to stick with something that's hypoallergenic, that's mild, and isn't going to cause skin irritation. That's sort of where I would just start, because we know this has an inflammatory component. And then if you want to step up and try some other things, Vash is a well-recognized wound wash, and I don't know if you've had experience with it, but it's safe. It would be reasonable to try. It has an antimicrobial property to it. So
I know a lot of people who have used it. I haven't used it personally. I did want to mention one thing on the Hibiclens is get the foaming applicator top. It goes much further if you do that, which makes the product much less expensive in the long run, and makes it much easier to use, because I know when I didn't have that, it would just drain through my hand. But the foaming applicator makes it so much easier to use. So I would definitely recommend that, and make sure that you rinse it thoroughly. And it may not be something you want to use every day, just because it can be harsh on your skin. So
2 to 3 times a week is what I typically recommend patients. 2 to 3 times a week, and then let it sit though. Sit for 3 to 5 minutes, and then rinse, but rinse thoroughly. So those are good points.
Yeah, exactly. So, but I found that product to be really helpful.
Yeah. Just like looking at this page that we have here. So the turmeric paste really I was trying to do some research on that last night, and it is something that I think is worth a try. also like with zinc, turmeric is anti-inflammatory. With anything that you try new to a skin condition, you want to start in a small area and see how your body reacts to it. If you tolerate it well, then expand that amount or area. But I think turmeric has good evidence for its anti-inflammatory properties in a number of conditions. And so whether you're using it topically or orally, I think that's a reasonable try. The thing I would say with any of these sort of supplements, whether it's turmeric, or zinc, I don't recommend it in excess. Don't go overboard. Use what's recommended. So if you purchase turmeric as a supplement, ask if you're at a supplement store or whatever the bottle says, like, don't go over that. Just use the amount recommended. Because I think there's a tendency to be like, well, if a little is good, then a lot must be better. And that's not necessarily true.
That is very, very true.
Okay, let's see if we go down a little bit here. So there's that Medipore tape we talked about. That's where affordability comes in. When I talked about those island dressings, they can be very convenient because they're already set for you, but this is what's on there. It's Medipore tape. So you could take gauze or you could take a foam and you could purchase the Medipore and then you can cut to sizes that you want. The island dressing has the Medipore attached to it.
Yeah, and sometimes, sometimes the island dressings or the bordered gauze can be a problem because if it's an area where you have hair, like on, in your groin or your mons pubis, sometimes that can be tricky situation. So I know sometimes it's better to use like the gauze and the tape so that you can put it where you need it specifically.
Yes. Yeah. Adaptic is great. It's an emollient base, so it's not going to have petroleum in it. So we've anecdotally kind of find that Adaptic, or it might be silicone. So Adaptic has two. They have a silicone base, which has no emollient or petroleum to it. And then they also have an emollient one. So what I would say there is it's nice. It's comfortable. It goes on the skin and it protects anything else from sticking to it. So if you have those wide excisions, but that are maybe fairly superficial, they're not very deep, that might be nice and feel comfortable. Same thing with that silicone contact layer. That's all that's meant to do is comfort, because those nerve endings are exposed, and by placing that sheet over it can sometimes reduce the pain.
Yeah, so these are wonderful products. If you have an issue with bandages or dressings, gauze sticking to your wound, this is where you want to go with that, because this prevents that from happening, but also is breathable so that it's not keeping your wound too wet or too dry. Yeah. So I had an issue with sticking, and it was very, very traumatic after a wide excision. And this product, it made life so much easier. Yeah. I didn't have to worry about that panic feeling anymore.
And those silicone, again, I try to get people to think about, instead of brand names, thinking about product types. So like silicone in general, if your silicone border or your silicone contact layer, those are going to be gentler on removal than some of your other tapes and adhesives. The Hydrafair Blue is something you and I have talked a lot about. It's a wonderful product. It's a foam, and it comes in a couple of different formulas, meaning there's some that are ready, so they're nice and soft and you don't have to activate them. And then there is the classic, which comes hard and has to be activated with saline or water. And the benefit of Hydrafair Blue is that it has some antimicrobial properties to it, and the foam is designed to transfer fluid, and that moisture wicking property of the Hydrafair creates a sort of negative pressure. It sucks down onto the wound bed, and by doing that, it promotes contraction. It stimulates sort of increased granulation, which is the formulation of new tissue. And so that's why in the wound care setting, we really like it. And I think you've experienced good outcomes with Hydrafair Blue.
Yes, very much so. And even before I became comfortable with using it straight on my wound, because I was such a baby for a little while, they did Adaptic an adaptic layer and then the Hydrafair Blue.
Mhm.
And even through that, it still worked wonderfully until I was comfortable enough to not have the adaptic. It
Mhm.
was like training wheels for a while.
Mhm.
But even through the adaptic, it still worked really, really well.
Yeah. Yeah. The only limitations I think in Hydrafair Blue is like what you said, is that the mechanism, which is why it's so effective, creating that negative pressure at the wound surface, does mean that upon removal, it can be a little to a lot uncomfortable. And so there's strategies to get around that. And sometimes we'll recommend patients just, if they can, get in the shower and just let water run over it till it falls off. Or you can really saturate it, sometimes putting a compress to it to help get it off without feeling like it's too uncomfortable. But oftentimes we'll put a contact layer underneath, particularly to begin with. It's an expensive dressing. It's
Yes.
probably something that you want to see a wound care center about so they can help get the right size and secure it effectively. Because if you're not using it effectively, it just becomes a really expensive dressing.
Yeah, it definitely has a place, but I totally agree.
No. And then the pads are great. I use them a lot in hidradenitis patients because if the wound size is just too big and we can't effectively place a Hydrafair, or maybe there's still too much bleeding and it would have to be changed too often or something like that, just a pad is great. And if I can't get a contact layer in there, honestly, I just tell folks to use the Vaseline uh, on the pad itself. Or maybe we put a cream down like a Silvadene or something to just make sure that what's against the wound bed is comfortable and that when they remove it, it's not traumatizing.
So for those of us with HS, after you have an abscess that bursts or drains,
Mhm.
and then you're left kind of with a hole
Mhm.
in the skin that's indented,
Mhm.
is the best thing to do for that would be like a petroleum jelly or an A&D and then put a pad over it?
Yep.
Okay.
Yeah.
And eventually that skin will grow in and come
Mhm.
up, correct? Okay.
Yeah.
And I
And
know that sometimes that can take a really long time though. I mean,
yeah.
it has for me in quite a few situations where it's like, are you kidding me? Is this going to be a hole forever?
Yeah, and I think that we don't know for certain, but likely it has to do with the amount of scar tissuing around the area. Scar tissuing will delay healing, and the disease process itself is inflammatory. And when we looked at the healing spectrum, right, what's the first stage of healing? Inflammation. So you have to get out of inflammation to progress to the other stages of healing. And this condition, and that, you know, this condition is often in an inflammatory state. So that's where it goes back to, like, topical management is one piece to help manage the associated symptoms, but disease management is so important. And so working with the dermatologist or making decisions about medical therapy or surgical therapy in the long run is so important. But I do think, yeah, like just a simple dressing to cover it, moisture balanced, and then thinking about reducing inflammation. So some of those salves that we talk about might help reduce inflammation. If you have a salve that has turmeric in it, or, you know, a lot of times hydrocortisone cream is something that I'll say, well, why don't we try a little over-the-counter hydrocortisone cream? Or sometimes we do a higher dose steroid for folks, but I think it's very reasonable to consider a low dose steroid, like what you can get over the counter, hydrocortisone, and mixing that with your salve and seeing if that helps reduce inflammation so you can progress to healing. If you think that you're infected, which would be not just, and it's hard with HS to delineate sometimes, but infection is really like associated warmth. You hit a red, warm, where I think HS is in its normal state is more painful and hard and draining. The real redness that's associated with physical warmth tends to be less common and more associated with an actual infection.
Yeah. And if you have any indication, most of us, our abscesses kind of, we know how they behave or what to expect from them. So if you do have an abscess that is not following kind of your normal course, then please do seek treatment for that.
Yes.
It's not something to put aside. And if you're thinking you may have cellulitis, a good idea is to draw the line around it to see if the redness continues to spread. We do have an article on cellulitis as well and things to be on the lookout for, but these aren't things to mess around with. So if you do have an abscess that is acting differently than your normal abscesses, then please do seek treatment for that.
And hopefully you have that connection with somebody who is going to, you can call and say, I need to get in and take a look at this, or go to urgent care if you can't. But if you're feeling sick, if you have a fever, if there's other symptoms outside of the local pain and inflammation, that's another indicator. If you're diabetic and your blood sugars start really escalating and you can't get them down, that's another indication that this might be tipping into an actual infection. And so you need to seek care for that right away. Okay, let's see. I don't know if did we cover, what are some other things? We can talk a little bit about, where's my last note that I wanted to, scarring. So just really quick on that. I think the most important thing about scarring, unfortunately, is that disease burden needs to be under control. Do you want to send it to me? I'll pull back my screen.
Yeah.
Okay. So the state of your disease, if you're in repeated flares, you're unlikely to be able to manage the scarring very well either. But we talked about silicone and how silicone sheets can help reduce pain when you remove them. So silicone sheets can also help reduce scarring. So you can use them just as a sheet over wounds, and hopefully that will reduce scarring from smaller wounds as well. But they also have things called scar sheets, which they kind of look like little strips. And you can try those in areas of hypertrophic scarring. It's not going to affect it overnight, but if you use it repeated, for several weeks, you might reduce scarring in some of those areas where you may have had surgery before, or repeated abscess or nodules that have been either deroofed or incised in some way. Vitamin E orally or topically is something reasonable to try. Again, I emphasize, don't overdose on your vitamin E. It is a fat soluble, so you can take too much of it. So don't think that you need to overdo it. But like the typical recommendation is 500 IUs per day. 400. And then again, hydrocortisone. And even in your acute flaring states, like maybe using that can reduce the inflammation. And if you can reduce inflammation, you may reduce scarring in the long run. So you can use the hydrocortisone, even if the wounds have healed, you can continue to put it in that area to try. We talked about how scarring and remodeling 21 days to 2 years. So, and then if you have extensive scarring, really you need to consult with a dermatologist or a plastic surgeon. And there are options out there to address that really extensive scarring. So I would just encourage you to, if it's really bothering you, talk with the dermatologist. There are lots of options out there. And then that's kind of, I just wanted to make one point that you and I had talked about beforehand. People were like, do I need to let my wound breathe? I always emphasize with patients is that we don't osmose air. We get our nutrients and oxygen from our blood, and that's how our wounds heal. Whether you leave a wound open to air really is most likely going to just dry out the wound bed, and a dry wound bed heals slower than a moist wound bed. So I always just recommend finding something that's moisture balanced that feels comfortable for you. Those are the two main things. Wish we had like one dressing that we could be like, this is the one, this is what you need to do, and everything's going to be fine. But
the miracle dressing,
but we just really go back to the tenets of moisture balance and comfort. And that's what's important. I'm going to just caveat that we may end up removing these recommendations that we had at the bottom about lifestyle modifications. And that primarily comes from this concept that a lot of things that are put out there for lifestyle modifications don't have evidence to support them. And they often kind of come with this like judgment that you should be doing something different. And the emphasis is really on the disease process, and that this is an inflammatory disease. And you really need to, find a team of providers that are going to help you treat it like we would treat any other chronic disease.
Yes, that's very true. And thank you for pointing that out. Yeah.
Okay, so, I hope that was helpful.
It was awesome. Thank you so much. And we're going to link everything down below, and then we'll add some of these things to our page as well for products, just so that they, people have a visual and can link to those as well from our product page. Because I think that's really helpful for people to be able to find everything in one place. And I was writing down too, like A&D and lanolin, so that I can add those products on there also. And then if you have any other suggestions, shoot them over to me and I'm happy to add those on. So
okay.
Thank you so much, Katie. I really
You're
appreciate
welcome.
your time today. It was wonderful. And I look forward to doing this again.
Yes, thank you.
Thanks.